So good afternoon. I'm Marcia Day Childress from the Center for Biomedical Ethics and Humanities here at the UVA School of Medicine. Happy to welcome you to our program today, What's Wrong with Me? The Hypochondriac, Uncertainty, and Anxiety in Medicine. Hypochondria, the morbid, even delusional concern about one's possible ailments, can be a catalyst for questions about how medicine can know and tell about patients' bodies. Northwestern University medical humanities scholar Catherine Belling argues that hypochondria today is less a psychopathology of any particular patient than a rational, although maladaptive condition that emerges in the gaps between doctors' and patients' understanding and expectations of medicine. Hypochondria also involves different ways that doctors and patients read. How patients read their own bodies and interpret their symptoms, then are read in turn by their physicians. How doctors and increasingly patients read informational texts for biomedical data. And also how both patients and physicians read and learn from the proliferation of cultural narratives about various disease states and illness experiences. In our program today, Professor Belling will look at how hypochondria figures within the world of medicine. As the term hypochondriac is most commonly used, it tends to mean a complainant who is not really sick, and who thus may be made fun of. In psychiatry, though, hypochondria names an actual mental illness, and so, at least within the psychiatrist's domain, the person diagnosed as a hypochondriac really is sick. And in primary care, the hypochondriac may be a person who pleads ill health, even though the doctor can detect in them no organic disease. This person's insistent, "What's wrong with me, doctor?" is a question that many physicians dread. In all of these settings, the hypochondriac is an anxious reminder of what is uncertain and unknown in the world of medicine. And the hypochondriac may personify both medicine's and the individual physician's difficulty in addressing and managing suffering in the absence of any objective evidence. It's a really great pleasure to welcome Catherine Belling here to UVA. As I mentioned, she's at Northwestern University in the Feinberg School of Medicine in downtown Chicago. She's an assistant professor in the Medical Humanities and Bioethics program there. She's a literature scholar with a keen interest in studying health anxieties and their expression in a variety of media, including electronic communications. Professor Belling is a leading edge in the new generation of medical humanities scholars doing admirable work that brings the methods and materials of the humanities to bear on some of medicine's most puzzling and persistent questions. She's just now finishing a book on hypochondria, so this talk I think you may consider something of a preview to what will, I think, be a very interesting volume. So welcome, Catherine.
Good. You laughed. Is the mic working? Does that sound okay? Good. Well, thank you very much, Marcia, for this invitation and for this opportunity to test out some of what's going to be in my book with real people, which is always kind of useful and a little scary. But I welcome as many questions and comments as you think to ask. You laughed. Woody Allen is our kind of stereotypical contemporary hypochondriac. He's intelligent, he's articulate, he's very anxious, and he's funny. And one of the questions that really led me into this work was wondering why hypochondriacs are seen as funny, as somehow someone that we laugh at. It goes right back to Molière, for example, his play La Malade Imaginaire, which is about the imaginary sick person, the person who imagined himself to be sick, a comedy making fun of Argan, who was this person who imagined himself to be sick. And it was only when the play was translated into English in the late 18th century, no, later than that, sorry, I've forgotten the exact date, and was named in English the hypochondriac, that it came to be associated with hypochondria, which in context at the time was much more thought of as a real sickness and as a real kind of psychosomatic disease, a condition, which I'll come back to that a bit. But right from then, the hypochondriac was funny. Quick example, has anyone here seen the movie Vicky Cristina Barcelona? Okay, a very much publicized scene before the film came out was the kiss between Penelope Cruz and Scarlett Johansson, and there was much excitement about how that was going to be filmed and so on. And on the day, as this headline suggests, Woody Allen, the director of the film, wasn't there. So he got to miss this extraordinary scene which he had invented and was going to be directing. Apparently it went ahead without him. The reason was, and this is how Penelope Cruz described it, he found a freckle on his hand this morning and he thought if he left going to the doctor until the end of the day it would be too late. So he went to the doctor instead. And of course that became, it was, as you can see from the title, clearly that marks him as a hypochondriac. The picture's rather nice too because it has these two incredibly desirable women and him on the edge looking out and worrying about something. He's really just not fully present with his actresses. I have my own theory that perhaps it was a way to deflect attention from a scene that was getting a lot of anticipation, and I believe that Woody Allen uses his hypochondria fairly strategically at times, and he's probably not the only one. But I think one of the questions it raises again is that idea of this being somehow funny. No one was worrying about whether or not that freckle meant anything, and it was never mentioned again. And we don't know about what happened when he went to the doctor, if indeed that was what he was doing. But we do think of him as funny, as though his priorities are wrong, because he found something and he didn't know what it meant. It was a sign, right, a mark on his skin that, as far as he was concerned, had suddenly appeared. And he had to go and have it looked at in case it was dangerous, and it was urgent. I mean, when he says he thought it would be too late, that probably doesn't mean he thought it would, metastasize by bedtime, but it does suggest that the need to have it seen and evaluated, and his need to be reassured to the extent that it was possible, was seriously urgent, not something that he could set aside. A quick initial idea of what hypochondria is. This is Carla Cantor, who is a writer who had severe hypochondria, was hospitalized for severe anxiety, and then wrote about it afterwards in a book called Phantom Illness. And she says to be thought of a hypochondriac as a crushing experience. And notice there she's not saying to be one, she's saying to be thought of as one, to be called a hypochondriac, in other words, is crushing. At best, the hypochondriac is a figure of fun, like neurotic self-absorbed Woody Allen. At worst, it's a terrible stigma. Someone who feigns medical problems for attention, someone who's pretending to be sick because they want attention. A crank, a faker, a fraud, and someone whose problems are all in his head. And obviously what follows from that is the idea that if they're all in your head, they're not real, they're not in the real world, you're making them up. The caricature of the whining, self-involved complainer who frets endlessly about imagined ailments is a long-time staple of the humour industry. What I want to do is think a bit more about that and about how that stereotype works in relation to medicine and in the clinic and in terms of what doctors are confronted with when they have patients who appear to them to be this kind of person, this kind of patient. But I want to historicize somewhat and go back into ancient history in an account of hypochondria all the way to 1972, which is an important period, I think, in many ways. And one of the things I'm arguing in my book is that a certain kind of hypochondria came into being around the late 60s and 1970s, and then what we call hypochondria now is very different to what there was before. And a great place to start to introduce that is Alastair Cooke. Does anyone know, what do you associate Alastair Cooke with? Yeah, okay, Masterpiece Theatre, right. He was a British journalist who became an American citizen in the 40s. In fact, the day that Pearl Harbor was invaded, he became an American, which is kind of interesting. But he was invited. He kind of wrote transatlantic messages. He wrote letter from London when he was still in London. They were used in America. I think they were on NBC. And then once he came here, he wrote his famous Letter from America, which came out once a week, right up until he died at the age of 94. But at this point, and this is him in 1972, which is also the same year that he started presenting Masterpiece Theatre on PBS. He was invited to give the Lloyd Roberts Lecture to the Royal College of Physicians of London. I'm not quite sure why, and in fact he says at the beginning that he's not quite sure why either he was invited to do this, but perhaps as a kind of transatlantic and very articulate person, he seemed suitable. And the talk he gave, he titled Hypochondria, the Layman's Specialty. And I'm just remembering that my quotes are here. And I want to just look very briefly at a couple of the things he said. And there's a clue there, the idea that he's talking about something that is a specialty, right, like a medical specialty, but it's the specialty of the layman. It's the specialty of the person who is not a professional physician. So he frames it right away as a kind of challenge and a kind of question about who's the specialist here, who knows the answers, who's in charge of the knowledge. And he begins the talk by setting that up. He says, I fear that I failed in the first requirement. I have not brought my slide projector or my cine projector or my overhead projector. This is 1972. He doesn't have the apparatus of the professional, of the scientific presentation. He doesn't have his AV equipment. But then he goes straight on. I have not even brought my chest x-rays or my GI series, although as an expert hypochondriac, I would love you to see them sometime. So he's playing with his doctors. First of all, he's identifying himself as a hypochondriac. So he says, I know my subject, I'm talking about it because I am one of the people that I'm talking about. But he also says he's an expert as a hypochondriac. And it's unclear whether he means his expertise is only in hypochondriac, if he's a particularly expert hypochondriac, or whether it's simply that all hypochondriacs have a certain expertise, the layman's specialty. And at the same time, he also puts the audience into that awkward, tricky position because he says, well, I'd love you to see all my slides and films, and at that point, physicians who treat hypochondriacs are probably, is this what you're about to subject us to? tell us your symptoms, and maybe we'll come up with a diagnosis while you have a captive audience. But of course, that's not what he goes on to do. So hypochondria, their works, he's setting it up as a kind of catalyst for a tension between patients and physicians. A clue about why 1972 is important, it's also the year that informed consent became the legal right of patients in the United States. And I think that that's not unconnected in terms of both the information part that patients were required from then on to be informed about their disease, about their diagnosis, about what was happening, what they could consent to, and also maybe more importantly, what they had the power to refuse. And therefore, the relationship between doctor and patient were different. Okay, and it's in the historical context of general kind of rebellion and resistance to authority of the period, and patient autonomy emerging in bioethics, that at this point patients were beginning to be able to say, you are not, the paternalistic system where a physician knows everything and says, no, don't you worry about it, when I tell you you're fine, is fading away, is being resisted. But what Cooke does is connect this particularly with language, and particularly with the word hypochondria itself, which is something that I'm particularly interested in and trying to develop on. In my book, he says, I promise to watch my technical language when he begins talking. He doesn't want to offend his audience by getting stuff wrong. He also doesn't want to reveal his own ignorance, and he's being very disingenuous. He says, I hasten to assure those of you slightly abashed by my title that I'm not going to talk about the lower part of the abdomen. The hypochondrion, the term originally was an anatomical term. In Greek medicine, the hypochondrion was this part beneath the ribs. The chondria was the connective tissue between the ribs, and the hypochondrion was what contained the spleen, particularly, among other things. And the spleen was the source of black bile, or melancholy. And of course, melancholia and hypochondria were very closely related. And as you can see then, the condition that was called hypochondria was thought of as physiologically caused by an excess of the humor of melancholy, which produced both physical and psychological, spiritual symptoms, or rather was constituted by those symptoms, really. So he says, well, you know, I'm not actually talking about that, as if you thought I was, and then goes on to explain why he called his talk hypochondria rather than hypochondriasis, which is the medical version of the word. He says, I debated for some time whether to stay with the lay term, and there's that lay word again, and he says he chose to be mischievous. I decided to use the word as a sort of bait or come on for pedants, for people who are strictly and fiercely correct about the use of words. This is someone who's known for his articulateness and his use of language. And then he tells a little story. Sure enough, the moment the title was announced, I had 3 letters, all from surgeons. And I remember he's talking to the physicians, and at this time in Britain, still physicians and surgeons are not the same. So he says, wasn't you guys also surgeons? But of course, he's really talking about doctors in general, saying in effect, I have already learned something from your title, that hypochondria means something other than the lower half of the abdomen, which I presume makes hypochondriasis a symptom. So he's saying that these surgeons are being facetious and pedantic, overcorrect, and trying to correct him, trying to pull rank in a way that this is our word, we own this word, you can't have it. Of course, they knew what Cooke meant when they fell into his trap. But they were trying, they just couldn't resist trying to make sure that he knew, that they knew better than he did what the word meant. It was their word, and he wasn't to take it out of their context where they could control it. And his conclusion is a diagnosis. He says, the promptness, or rather the subdued hysteria of this response, suggested that we might add a useful footnote to this lecture on hypochondriasis among surgeons. And we can think some more about what that particular diagnosis means here, about anxiety and the need to be exact and precise and have it right, which I think is connected. And then he goes on to give a very amusing taxonomy of various kinds of hypochondria, which is mostly funny. And I think his point really has been made at the beginning. About language and about who gets to decide what the words mean and how they work. But let's try and, based on that, find a better or a more precise definition. And so I want to go outside of the medical terms and look at someone who calls herself a hypochondriac, a self-identified hypochondriac. And let's look at some of the characteristics. This is from the hypochondriac.com, which is a fascinating website. And this is one of the many posts. There was something like 2,800 new introductory posts from people. A lot of people introduce themselves and never go back. And I should also say, the site has many password protected conversations and chat rooms and things. I've, in the book too, only used things that were outside of the protected part and that are completely publicly available. But this person introduces herself and tells us something about how she thinks hypochondria works. I'm new here. I have never been diagnosed professionally that I am a hypochondriac. It's not a diagnosis. I haven't been given the diagnosis, but I really believe that I am. What's this based on? I constantly think that I'm sick and dying of something. I'm always going to the doc and they give me the all clear, so I'm not sure what's going on. So there's a real contradiction there. I think that I'm sick and dying, and the doctor gives me the all clear. So they say, you're fine, right? So I'm not sure what's going on. And then things get a bit more complicated. I just cannot seem to get it out of my head that I have lung cancer or some sort of throat oral cancer due to my smoking habit. That's not irrational. They've been connected, right? And in terms of public health, she should be worried about that, right? That's why and she doesn't talk about stopping smoking. Clearly that's where this should be going, in which case it would be healthy health anxiety, right? It would lead her to reduce her risk. She doesn't, that doesn't seem to be an option. I'm 34 years old, female, married with 2 children. It gets so bad to the point that I just cry in the shower so no one will see me, because I am so scared that I have or will soon get. I might have it already, only no one knows about it, or I will soon get it and die and leave my family behind. This is not funny. This is someone who's suffering. This is someone who's very frightened and kind of lonely. And it was encouraging to see the kind of comments that she got back that were extremely encouraging to her, I think, in various ways. But then she ends, and here's another important piece, I am Googling all the time to see what I might have. And I know that's probably not the best thing to do. Tell me I'm not nuts, please. Googling is an incredibly important part of hypochondria now. It's being called cyberchondria, in fact, it has its own term. And there's an article about it was published in the New England Journal quite recently. Also, Microsoft commissioned a study on the health effects of symptom Googling. And the likelihood that they would increase anxiety rather than producing a realistic, accurate diagnosis. But nevertheless, there's something else here that tells us she has access to a lot of information. She can Google her symptoms. She doesn't have to go and ask somebody. She doesn't go directly to her doctor. She looks them up. She does research to try and figure out what she has. And she also recognizes, culturally, something has told her that that's not probably the best thing to do, because she probably spends far more time in the incredible hypertext of symptom Googling. And if any of you have ever tried it, probably most of you have at some point, right? But eventually she will find the worst possible outcome, and will come from pretty much any symptom she puts in, and she will then get worse. And then her ending is also interesting. Tell me I'm not nuts, please. It's interesting that she's worried about cancer, and she's not saying to them, tell me I don't have cancer, please. She's saying, tell me I'm not crazy, because this disconnect between my doctors saying I'm fine and my fundamental sense that I am sick is causing as much suffering, perhaps, as her fear, because her fear, as you can tell, is isolated. No one else is feeding into this fear. No one else is helping her with it. She cries in the shower because she believes she has cancer and no one else believes it. So she's not being treated, she's not being helped, and she doesn't even have anyone to talk to about this. So this is not entirely funny, right? Even though you can tell, even in her tone, she's trying to be funny. She's trying to make light of it, I think, at some level. All right, so from that we can put together a kind of definition, and this is what I'm using to try and get outside of being reliant on either on a clinical or psychiatric definition. It's an illness characterized by a patient's pervasive fear that either she has or she's about to get a serious disease. It's based on the patient's reading of subjective bodily sensations and signs. And notice that I'm not saying symptoms. The patient reads things that their body does or feels or manifests as symptoms of serious disease. In other words, things that someone who's not a hypochondriac would not think of as a symptom. You know, a slight weight or pressure, or a slight sense of disorientation, or feeling tired, or just a passing headache, that they would probably not even think of as a symptom so much as just their body adjusting to the general kind of equilibrium that we all have to manage. They read everything as symptoms, therefore as things that have meaning. And this happens in the context of the patient's medically informed hypothesis, that these patients always are thinking about their bodies as already things that medicine has to make sense of, rather than any other kind of a healthy organism or something that's adapting to its environment. Rather, they're already thinking of their bodies as a puzzle for medicine to solve. And their anxiety is resistant to medical reassurance. They're not persuaded when the doctor says, I've done all these tests and can find no objective evidence of disease. You fear you have cancer, but I can't find it. Therefore, either you do not have, the wrong answer is either it's nothing, it's all in your head, you're making it up, just go off and live a happy life. Stop bugging me, stop worrying. Or a better answer is, I don't know what's wrong with you. I don't know what's in you. I can't find any evidence. So at this point, we can trust that you're okay. And that is a better answer, but it's also not completely persuasive, partly because the hypochondriac believes in medicine implicitly. There's a kind of assumption, and I think among many doctors too, that hypochondria produces a distrust in medicine, an antipathy towards medicine, whereas in fact it's based on the assumption that medicine could solve me, medicine could find the answer to what's going on with me if only I could find the right doctor. And that's the problem, that the belief that medicine would be able to find the answer, or in future, they're going to discover the technology that can uncover my problem tomorrow. So I've got to keep going back. And that's one of the things that produces the very painful tension where the patient goes to the doctor with high expectations and is always inevitably disappointed until they get bad news and a very serious diagnosis, which comes as a very ambivalent relief, which produces the sense that the patient wants to be sick. And I don't think that's strictly true. It's much more a matter of wanting an answer, wanting to be known. And because of the way medicine works, that can work with a positive diagnosis of something. It doesn't work if you're just simply told we can find nothing. There's nothing in you that means something. Okay, and so very quickly, just the things that, in terms of this definition, that are very often confused with hypochondria: malingering, in other words, pretending to be sick, deliberately pretending to be sick because you want attention or to get out of work or whatever. The difference there is that that person knows that the symptoms are being falsified. There's an awareness that underneath they believe that they are well, or at least they believe that they're well enough that those symptoms are made up. So therefore, there's a control over that. And a sense of being the subject of what's going on. MUS is even more tricky. Conditions where the symptoms are the most important thing, and what the patient wants is to have those symptoms go away. And these are increasingly common, and they've been given names which point to the fact that they are syndromes constituted by a cluster of symptoms rather than an identified objective lesion or disease. I mean, some of those are changing, and things that, again, medicine does make progress, and actual disease etiologies have been discovered for some things that were in the past considered simply medically unexplained symptoms. But if you think about the patient we were just looking at, she doesn't talk about her symptoms. She says she worries about what her symptoms mean, but she doesn't ever actually say, I've got this terrible headache or whatever, or this terrible inability to breathe, or this lump. Or that's not what's important. And particularly, that's not what she wants her doctor to pay attention to in terms of getting rid of it. In fact, the person with hypochondria often worries that they don't have enough symptoms, as if only there were more symptoms, I would be easier to read. There would be more clues to get to the answer. And one of the big problems there is if a physician responds to the hypochondriac by saying, well, I'll give you these analgesics and the pain will go away, in a way that can seem like hiding the one clue you have to the terrible thing going on, and therefore it will be able to continue to hide inside you. So that's another problem. Delusional, that simply means that hypochondria, and this is in the psychiatric term as well, the fundamental issue is subjective experience. They're not, the hypochondriac is not saying, I've got a terrible rash here, and when the doctor looks, there's no rash at all. The things that concern them are things that can't be proven not to be present. In terms of the symptoms, I don't mean in terms of the cause. And then somatization, and there's probably the most overlap here, but somatization tends to mean that the body's symptoms and the patient's belief in disease is really a response to a psychological upset, to some kind of mental issue, usually interpersonal, social question, which if you could just sort that out, the symptoms would go away. And that's very often true. As I say, there's a massive overlap here. But what that does is kind of do the opposite. It's psychologizing something which is the body is quite sufficient in terms of producing anxiety, that symptoms are real, and the patient's anxiety about having a disease can be quite sufficient without that having necessarily to be the projection of some kind of intracyclic conflict. And so there's a danger there to dismiss the bodily stuff and look elsewhere rather than focusing on the fact that the patient's real worry is the same thing that medicine worries about, trying to find the cause, trying to catch disease in time to do something about it, and so on. Okay, and the reading part is huge here, and if you track down what hypochondriacs say, it's amazing how consistent this pattern is. I began to get all these weird arthritic symptoms, and I went to the doctor, right? No, the library, because I was having some rashes, some arthritis, and I happened upon a book about lupus, and that was really the beginning. Carla Cantor, became so absolutely persuaded that she had lupus that she became obsessive about tracking her symptoms and her signs, and to the extent that she really did nothing else but look for signs of lupus in herself until eventually she had to be hospitalized. And her story is about Prozac, which, in terms of her book, she was cured by Prozac. And we can, if there's time for discussion, when there's time for discussion, we can talk about that some more too, the role of SSRIs there. Here's another one, Gene Weingarten, and I like his title, The Hypochondriac's Guide to Life and Death. And so when I felt lightheaded for a month, I leafed through some books and determined it was multiple sclerosis. So you have the same thing again. You'll also know, I noticed reading these memoirs, and there are several of them, but not that many. When hypochondriacs write about their own hypochondria, they have to be funny. It's as if it's absolutely essential for the narrator to separate themselves from that absurd hypochondriac over there who is themselves and make fun of them in order to disclose their own fears and anxieties. And that's a real constant throughout, in writing online and in books, that it actually produces a sort of division. Because the person being remembered always turned out not to have the thing they feared. And so you'll have someone, Jennifer Traig, whose book is called Well Enough Alone, where she writes about how she, all these absurd things she used to fear and how she doesn't feel that way anymore. And then as she's writing, near the end of the book, she says, as I'm sitting here, I have, and then she goes through the list of things that she's worried about. And it's very clear that she is still absolutely a hypochondriac, but doesn't see herself as that. She thinks that the retrospective protagonist of her story is, but she has these genuine fears. And of course, the important thing to remember is that, sadly, being a hypochondriac doesn't actually protect you from anything. Just because you're paranoid, it doesn't mean they're not following you. That one of the most extraordinary books like this is by John Diamond. It's called Because Cowards Can Get Cancer Too. And it's his story. He was a writer for the London Times, and for a long time wrote about his hypochondria and sort of commented on the world through that perspective. He was very afraid of heart disease, so gave up smoking, started chewing nicotine gum, and eventually developed cancer of his tongue and esophagus, which did eventually kill him. And this book really is about being a hypochondriac who was really kind of terminally ill with hypochondria, you could almost say, or caused by it. But it's an amazing, it gives you an amazing insight into how being afraid of something doesn't actually protect you from getting it. And there's a piece in that there, as if I worry about it enough, I've already suffered, so I won't actually get it. It doesn't work like that, sadly. Here's one more, and there are lots of the childhood ones. I've been a hypochondriac for nearly the whole of my embarrassingly healthy life. It started with my grandmother's fault. She owned a medical encyclopedia. So he got information about medical stuff, and medical knowledge can make you think you're sick, especially if you're a lay person. And one of the pieces that I won't have time to talk about much now, but which I believe is very strongly connected to this, is that preclinical medical students are rather like lay people who get into the medical encyclopedia. I'm sure you've all heard about, and some of you have no doubt experienced, medical student disease. The idea that early in medical school particularly, you start getting the things you read about, or believing you have them. And what happens, and studies have shown this, as you enter the clinical years, that stops by itself, which is why it tends not to really be dealt with much in the curriculum, which I think is interesting. As you become thoroughly no longer a layperson, as you put on the white coat and become the doctor, you then manage that information more thoroughly, or one might argue you repress your own identification with those symptoms and things. And I do believe that there's a clue there for why the hypochondriac is such a very challenging patient, that the doctor's been there and got over it. And now the patient comes, and they have these days access to, plenty of medical journals and Google and so on, and are kind of like those medical students were when they had the information but not the way to manage it. Okay, and so medicine deals with this by trying to avoid the term because of all the baggage it carries. I like this purely because of the imbalance between the quotes on the bottom. The term hypochondria is inaccurate and pejorative, and that's kind of out of context. I mean, he doesn't provide a context for it. So inaccurate in relation to what? What's it trying to refer to? And pejorative, it makes fun or says bad things about the person to whom it's applied. So instead, this is Brian Fallon, he's a psychiatrist in New York. They have the Columbia University, a New York State Psychiatric Institute program for the study and treatment of heightened illness, concern, health anxiety, and medically unexplained symptoms. That's not going to catch on, I don't think. The thing that he focuses on, what he usually calls it, is heightened illness concern, or HIC, which somehow doesn't have the same power. And I think although the word has negative power, I think it also has a certain power that is important to hold on to. Not least because it has that meaning that is powerfully there. My favorite of all of them is the hyperreactive somatose. I practice, but I can't. Hyperreactive somatose-sensory syndrome. And this was in a self-help book for hypochondriacs, The Health Warrior, which, if you said, has a lovely kind of powerful sound. I'm a health warrior, right? That it's a very good homophone. The DSM, the Diagnostic and Statistic Manual, the psychiatric handbook to making diagnoses, calls hypochondriasis this. It's one of the somatoform disorders, which is a kind of grab bag of mental illnesses that are connected with bodily symptoms or bodily perception, or the body in general. And they define it as a preoccupation with fears of having, or the idea that one has, a serious disease based on the person's misinterpretation of bodily symptoms. And second, the preoccupation persists despite appropriate medical evaluation and reassurance. And I think what's particularly interesting there, if we're thinking about reading, is that, in other words, hypochondriasis is defined as misreading. The hypochondriac is the person who gets their interpretation of their symptoms wrong, which of course assumes that there is a correct reading, a single correct reading perhaps, that there's a way to be entirely sure that their misinterpretation is a misinterpretation rather than a correct one. And that balanced against that is the correct reading, which is appropriate evaluation and reassurance. And while it makes sense and it's persuasive, there's also a sense there of an incredible burden being placed on the primary care physician, who is the one who has to carry out the appropriate evaluation, whatever that might be, and provide the reassurance in whatever terms seem appropriate. And again, the response there very often for the primary care physician, who is always necessarily the person who makes the initial diagnosis of hypochondriasis by finding no evidence of disease, is that one response, obviously, is the defensive one, which is, and this is kind of where Alastair Cooke is coming in, I think, too, the defensive and therefore also hypochondriacal response of saying, okay, we must do every test there is to make sure that I'm not wrong, and you're not, and that you are wrong. And then we can call you a hypochondriac, but first we will do every invasive test and so on. And the patient will be quite happy to go along with that, because now the two of them are working together to read the body, to understand what the patient might have inside them. And so, the full body CT scan, the unneeded MRIs, and obviously they have the exposure to further risk, which will then lead to further anxiety later when they read the article about repeated MRIs causing cancer and so on. So there's this incredible vicious circle, because the final answer can never absolutely be found, not least because the final answer will be I have looked at everything in your entire body and find absolutely nothing wrong. You're a completely healthy person and will be forever. And I'm going to check every single day. You know, that's the ideal. I know you completely, and you won't die. And the trouble is that for the physician, again, there's the recognition that every single patient will die eventually and will probably get sick before then. So that there's a kind of losing battle there too, that everything is provisional and temporary, but has to somehow be denied at the time because, you know, for obvious reasons, the same way as you know, with how many livers in this room right now, we can't all think about them all the time because we'd be distracted, to say the least. There's certain things that you can't pay attention to all the time. So there's a contradiction here, right? You have Jerome Groopman, MD, and this is a very interesting article. It was in the New Yorker a couple of years ago. In an interview about this article online in the New Yorker, the interviewer asked Jerome Groopman, why do doctors hate hypochondriacs? And as I was reading it, I was thinking, oh, and his answer is going to say, no, we don't really hate them. He said, the reason we hate hypochondriacs is, and he gave 3 reasons. And I thought that was very interesting, that kind of acknowledgement that you're right, we hate them. But he says hypochondria is the irrational fear of illness, which I find fascinating. Is there a rational, I mean, is it rational not to fear illness? Is there anyone who doesn't, at some level, fear, particularly serious disease, which is what it usually is? I mean, I think it's fairly mentally healthy to fear disease. And balanced against that, you have John Diamond, who's the one I told you about, who has cancer. And this is the first sentence of his book. In the face of such overwhelming statistical possibilities, hypochondria has always, and not only now that he's sick, seemed to me to be the only rational position to take on life. And what's interesting too is hypochondria is not a diagnosis or a disease, it's a position. It's an epistemological position about knowledge, about what you should know and how you can control what you know about as you learn it. And then hang on, I'll go back first. There was a study in the American Journal of Psychiatry a couple of years ago. The lead author is Arthur Barsky, who is at Harvard and has done a lot of work, and he's the one who actually did the study that showed that a combination of cognitive behavioral therapy with SSRIs, antidepressants, is very effective in treating hypochondria. But he led this study, which was about risk perception regarding health risks and medical procedures. And what they did was they had 2 groups, people diagnosed with hypochondriasis and people who were not considered to be hypochondriacs. And the conclusion, and they were both asked to rate various risks, the conclusion was what you would expect. Hypochondriacs perceive medically related choices as riskier than non-hypochondriacs do. And that was their conclusion, and that was what the article, I mean, it didn't seem like the sort of conclusion one really had to do a big study to discover. But somewhere buried in that was this, which didn't really have a place to, they didn't really have a place to put it. It was in the commentary. Although hypochondriacal patients feel a greater sense of risk than non-hypochondriacal patients, they nonetheless maintain an optimistic basis and as a group perceive themselves to be less at risk than others of their age and sex. In a sense then, it's the non-hypochondriacal patients who are manifesting a cognitive distortion, since they are more inappropriately and unrealistically optimistic and dismissive of the medical risks they face. It seems to me that is a rather more powerful conclusion if you include the third element, reality, against which they are all optimistically biased, including the hypochondriacs. And so this raises a couple of really interesting questions. One of them is that there really wasn't a place for that in the study, that it was something that was kind of thrown in a sense then, but that's not what we're looking for. And at the same time, it asks a great question about rationality. That the hypochondriacs are their thinking is less cognitively distorted than the healthy patients, and yet the assumption has to be that somehow rationality marks mental health. Whereas in fact what this is saying is that the less rational patients here were healthier. They didn't have hypochondria. And I think there's a really interesting piece there in terms of how hypochondria, how rationality is assumed to be a measure, sort of, in terms of medicine, the more you know, the more exactly you know it, and the more rationally you can process it, the healthier you are. Anything off that is starting to edge to ignorance or craziness. And I think if you uncouple those two and recognize that in the same way as you all know you have a liver but you can't think about it all the time, there's certain forms of cognitive distortion which are absolutely adaptive and essential. And I think one of the problems with the hypochondriac is the idea that they might be right, and that's why we've got to laugh at them or reject what they say or doubt them. Because actually we are dependent on a certain level of cognitive distortion in order to function healthily. And don't get me wrong, my argument is not that we should all become hypochondriacs. My argument is that one should stop expecting on one side this absolute adherence to rationality and maximum information at the same time as saying you're wrong to be closer to the reality about risk. And of course you've got the other mixed message from public health, which is constantly saying, early detection, screening, you too could be at danger for this. You must act. And of course that, is again sending a very different message. Okay, I'm not going to spend much time on this. This is the history that I wanted to look at. Was looking at the 60s and 70s and how so much changed in medicine and in society generally, and how I think all of these pieces, which we could talk about, was just a real list, put the patient in that position of the lay specialist that Alistair Cooke talked about. They are informed. The information isn't always appropriate or accurate, but they have a lot of that information nonetheless. They are given information to consent. They are given autonomy. They're expected to take control of things. They no longer are allowed to let their doctors simply look after them unquestioningly. And there is a burden involved there, as well as many obvious advantages. So really quickly, in 1934, we have Dr. Robert Hutchinson writing about hypochondriacs, and his argument is you shouldn't try and cure hypochondria. Why deprive the patient of his main interest in life? Listen to him patiently, examine him thoroughly, reassure him confidently, maintain the appropriate performance, give him some explanation of his symptoms, because he needs an explanation, and that's perfectly sensible. Prescribe a placebo so he has something to take and hold, and send him away happy until next time. So it works, but you also know that it'll only work for so long, and then you'll do it again. And then he adds another piece, and this is something that's obviously changed massively. I say nothing of the unwisdom of killing the goose that lays the golden eggs. Hypochondriacs were great patients. They came back often. They were not really terribly sick. You could make them happy fairly easily, and they paid. And with fee-for-service, it was a really nice, secure background of the patient who would come back and pay you, and it wasn't a lot of trouble. That has changed radically, and I suspect that a big piece of why doctors hate hypochondriacs now, not that Jerome Groopman said it, is related to that piece, that now they use up resources, and we don't like that. 1978, this is in the midst of the change, and where doctors here are starting to talk back to these rebellious patients, and this is one of the examples, the Klinger. And this was a famous article which caused something of a ruckus, I think, when it came out. The Klinger escalates from mild and appropriate requests to repeated, fervid, incarcerating cries for explanation, affection, analgesic sedatives, and all forms of attention imaginable. Such dependency may eventually lead to a sense of weary aversion towards the patient. But you get the other side, Arthur Barsky writing, and this is his more sort of writing about anxiety and illness for a popular audience. And he notices that being a patient is far more demanding and exacting than it used to be. You require more factual information, you have to manage it, you have to observe and regard yourself in a clinical fashion. You have to become your own doctor at some level, again, epistemologically. So to the burdens and fears of being ill, you now also have a certain amount of responsibility. And that's increased more and more with the idea of, with patients having to manage various specialties and various caregivers. So to end up, I want to look at, and this is kind of where the book ends up too, is to suggest that hypochondria is a way of thinking about medicine, a way of thinking about postmodern medicine, and how, to some extent, what I'm arguing is that the hypochondriac, in the way they approach knowledge and interpretation, have become somehow postmodern, and that the hypochondriac patient kind of stands in for most patients and all patients at some point. And that the trouble is that medicine, and I'm not saying individual doctors, but particularly medicine and the way doctors are trained, has remained thoroughly modernist. that rationality is always the most necessary and important thing. If you can't find objective evidence for it, it's obviously not there, and so on. This quote, I think, sums it up. This is Clifford Geertz, the anthropologist, talking about his field and how it's changed since, particularly over the course of the 70s. And one of the things he says is, our subjects look back at us now. And I think that's, and analyze us. And I think that's very close to what Alastair Cooke was doing. He was looking back at the doctors and saying, you know, I'm the expert here. And he actually uses the term that anthropologists now are harassed by grave inner uncertainties, and it's a form of epistemological hypochondria. Okay, and then I use, David Morris, in his book about postmodernism and illness, says perfectly, it is tempting, if ultimately erroneous, to identify the distinctive postmodern illness as culture-wide hypochondria. And if you were here, I'd argue with him, but I don't think it is erroneous. He defines hypochondria as necessarily the absence of danger. That if you're a hypochondriac, it means you're not really sick. So that he goes on to say, no, there are far too many dangers to make hypochondria appropriate. And my argument is, of course, that hypochondria is not about not being sick, it's about doubt. It's about uncertainty, and that's the place that it complicates things. So just to end up quickly, and this is the sort of standard rationalist position of modernist medicine. You see, there's nothing to worry about when you know what's there and you know how it works. So you've got to open, and this is someone who became a physician by, he was very nervous, so his uncle, who was a surgeon, anatomized a cat, showed him the insides of the cat and described everything and explained how it worked. And at that moment his fear went away and he decided he would become a doctor because he would never be afraid again. And then, as you can imagine from the title of the story, he encounters a hypochondriac patient and he ends up becoming, well, he falls apart completely. It's a terrible shock. And so here's another statement, which is, and this is my last slide, this is the alternative at someone else from that site. And she has a fear of brain tumors and she has a terrible headache. And she says, I'm going to have to get a freaking MRI to make myself feel better. And aspirin won't work. That'll just make the headache go away. She has to have an MRI. And it sounds the same, right? There'll be nothing to worry about if you can see what's in there and how it works. But the differences are that she's the one who's saying it. This is a patient saying, I've got to get myself an MRI. And the idea that what's going on inside will be something that she knows will make her feel better temporarily, but that the illness will come back. And particularly if the doctor can't manage that ongoing fear. Okay, and we have some time for questions. Thank you.
Thank you. So we do have some time for your comments and questions. I have a comment or question. No symptoms. I did want to ask, I'll take this over.
I'm Danny Becker, and I'm a doctor, and I'm a hypochondriac, and not really, but just for the budding hypochondriacs in the room, it helps to marry a doctor. I married a doctor.
That was what Moliere's hypochondriac, he wanted his daughter to marry a doctor so that he'd have one always in the house.
If you go back to the slide of hypochondria and postmodernism, I'm sort of trying to make sense out of the distinction between hypochondria and all the other kinds of malaise that we can never really categorize. And chronic fatigue, fibromyalgia, chronic pain. It seems like the hypochondriacs are sooner or later get all kinds of information and all kinds of it's not this, it's not this, it's not this. So they are making sense of the world. There's just not a lot of sense. There's insufficient sense to explain what's going on. Whereas my sense in dealing with other vague disorders is that people seem to need the disorder, and that there's more of a rejection going on. So I guess what I'm asking is how do you, aren't all of these lumped together? I don't understand the distinction between hypochondriasis and other somatoform disorders. And are you able to bring all of these together in some way?
They're obviously closely related, and as I said, particularly with somatization, which I think is very much what you're talking about, there's real overlap. But hypochondria, and you can see it in the way that Clifford Geertz uses this here, and I think what he's saying about anthropologists applies less to patients than to doctors. The idea of hypochondria as being a particular form of uncertainty based on the assumption that certainty should be possible, and that it's about meaning rather than about symptoms. So in other words, for someone with an MUS, the medically unexplained syndrome, symptom syndrome, the issue is the symptoms. For the hypochondriac, the issue is what the symptoms might mean, and the assumption that there is somewhere an underlying meaning, and that the meaning is what's important rather than the symptoms. The symptoms are the language that gets to the way of getting to the meaning, which is the Foucauldian lesion inside that medicine has to uncover.
And do you have any sense of the epidemiology of this? I mean, how many hypochondriacs are there? It doesn't come into primary care practice very often the way these other things do.
That depends on your definition, which is again one of the problems.
Yeah.
If you were to look at the people, if you were to go to this website, the patients who consider themselves to be hypochondriacs are the ones whose doctors keep telling them everything's fine and they go away, and then go to another doctor. And I'm not sure that a medical survey would provide an accurate epidemiology of people who experience, what I'm calling hypochondria. So I think that's a piece of it, and certainly in terms of psychiatric diagnoses, it's not up there with many other things. Although one of the other bits I wanted to add, the DSM is being revised now to be the DSM-5, which is expected to come out in 2013. If they can get it together, it's been delayed once. There's a lot of fighting going on about various categories, but the idea is to throw out the term hypochondriasis, and the fight is whether the condition that it describes would become part of OCD because of the obsession with disease and the compulsion to keep going back and checking to find out whether or not it's there, or anxiety disorders because of the fear component, the anxiety component. And so at the moment it's kind of there's a struggle over what exactly it is, which I think is really, really useful in terms of defining more clearly what it might be and how it presents.
Just in closing too, I would wonder if sort of in your historical timeline, to what extent might our population of the worried well be kind of replacing the category of hypochondria?
Oh, I think absolutely. Which is, and therefore, I think that might be a good move. First of all, it's a problem because it assumes that you're well, but I guess as long as you...
But it may not feel like it.
Right. Or
we feel guilty if we do.
Right, yeah. But I think if you look, that 1934 article that I talked about is called Hypochondria, Individual, Communal, and Vicarious. The communal and vicarious are no longer considered illnesses. Vicarious is particularly parents who worry too much about the health of their children, which is really, I think, largely considered a virtue, even though it's obviously very troublesome for some pediatricians because it wakes them up with frantic phone calls in the middle of the night. But what he calls communal hypochondria is now business as usual, certainly in Western society. And he complains about how there's some doctors who now talk to the press and cause health scares, and how he thinks doctors should not talk to the press because it just worries people. And which I think.
As we've come to the end of our hour, I would like to thank Catherine Belling for her talk and for the the thought-provoking ideas that she's brought to us. I would like to thank all of you for being here with us for this fall semester. Today is the last of our Medical Center hours for the fall. The series resumes for the spring semester on the 26th of January, and just watch for announcements about our programs then. But thank you for giving us a good fall season, and happy holidays to you.